Assalamu alaikum. I would like to thank Dr. Adel, Dr. Ahmed Abdul Aziz, Dr. Muhammad Jamal Mursi for the invitation. And here we're talking about tips and tricks in revision ACL surgery. Why we talk about it? We know that failure ACL surgery is increasing rate. It's about 4%, especially with the younger population that involved in sport activities and having their surgery at younger age. We can see here that it's almost a threefold if they have an injury at their teenage and they have the surgery at that time, they will have more revision as compared to 20s. So this is will bring us to, if we want to nail anything, we need to say why. That's the most important, because if we know why, we know how to deal with it. For the patient, he will always ask, why did it fail? And do he really need to do a surgery again, or what's the result that he would expect? For the surgeon, you need to know why did it fail again. So the same question for both, so we can avoid repeating the same mistake. And other question, we need to look at the technicality, and that comes second. But why it failed, it's important. So when we look at the review here, we have technical errors is almost 2/3 of the failure as the Pittsburgh classification for ACL graft failure. You can see here. So how we address it? It starts in the office. It starts with the physical exam, taking more history about the surgery, timing, how did it happen, what other pathology happened at the same time. Also, with the physical exam, observing the gait, looking at his position, as we just said, malaligned knee is very important, and also examine the other ligament around the knee to make sure that there's no concomitant injury as well. Imaging, we need to get plain x-rays. Sometimes we get easy doing MRI for everybody because we know there is an ACL, but looking at the x-rays, checking the slope, check the knee alignment, and especially in the revision, we need to see if there is any tunnel widening, is it in the right position, and if there is any arthritis developed already or not, what stage. And we need to get the MRI to assess the graft, the cartilage damage, the meniscal tear, and the CT scan to assess the tunnels and bone loss so we can address it. So if you look at this patient, this guy is a valgus tibia. He's a post-traumatic, so if you want to correct, you need to correct the pathology where it is. It is very rare to have a valgus tibia itself. Usually we correct it in the femur, but if you correct the femur here, you will add more pathology to his joint line. And if you have to see the posterior slope to assess the alignment. So, what we need to get from the CT scan, we need to get position of the tunnels, orientation, and the size. And we need to see the diameter to see if we can fill it with one stage or two-stage pathology. Do we need to bone graft it, or we can use like a BTB graft, and that will work. So let us address one by one. We know that from my previous speakers that femoral tunnel is the most common mistake. Will get malposition. It's almost 36 here in this study as compared to tibia, which is 11. So position of the femoral tunnel is important, and we can get it with the CT scan. So what to do? If we have the femoral tunnel is too far anterior, which lead to graft failure and flexion, we need to assess, is it too anterior, so our new tunnel will not interfere with the previous one? If that's the case, then just go ahead. It's like a primary, so you don't need to worry. That's the easy scenario. You get your own tunnel, if you want to fill the old tunnel with a screw or a bone plug, that's an additional. If it's not interfering, basically you didn't need to worry about it. You can just ignore the metal that was inserted there. What about if it is very close to your new tunnel, which little anterior? There is a chance that it might open to the femoral tunnel, then you create. So in this case, you need to cheat to get like to the overtop position, for example, or if you bend the knee to around almost 120, your direction of your drilling will be different. So you might join the orifice of the tunnel, but the depth of the tunnel will be directed to another uh, portion of the distal femur. And sometime you can, if it's converging at some point, you can use a shorter screw to block the interior part of the previous tunnel and just drill behind it. And this is, you can deal it with the bio screws. The worst case scenario, you can drill your tunnel where you want and use suspensory mechanism to fix the graft and insert a screw anterior to the graft at the joint line to keep it from slipping anterior. So what about if you blow the posterior part and you have no posterior to put your screws? I think this part is easy. You can use a suspensory fixation like most of us use, and or you can drill interference screws from outside in. This way you can have a more fixation proximity and the tunnel. Tibia tunnels is another issue, especially if you have a two anterior tunnel. You can aim for your graft and to try to see where your tunnel will be and see if they are merging. If they are merging, then you need to do you can use an osteotome through your previous one and push the bone graft anteriorly to fill the previous or anterior tunnel. You can put a screw in the anterior tunnel and you ream your tunnel behind it. So that might, if you're using especially bioabsorbable tunnel, you can use that. And you can chamfer your back tunnel also. What about tunnel widening? We need, as you say, the CT scan to assess. If it's more than 12 to 14, then you need to worry about having a bone graft and two-stage. If it is within 12 to 14, you can use a BTB graft or you can use large screws. Sometimes I use size 11 diameter screw bioabsorbable to fill the defect. So if it's a tibial tunnel is large, if it's a huge, we need a bone graft and two-stage. If it is a small, we can use one stage with bone block. If both are both femoral and tibia having large widening, then definitely this is a BTB. This is two-stage graft where you graft and you come back in a few months once it's healed, and at that time you do your revision. Hardware, if it's not interfering with your way, leave it alone. If it's interfering, you need to remove it. So address the pathology and the situation you have at that time. Concomitant procedure, as we talk about closed wedge osteotomy, especially for posterior tibial slope, if it's more than 12 degree, it's a must. Dr. Qadi would describe it very nicely. And having a closed wedge osteotomy is preferred for repair. In all my revision, I always add the lateral extra-articular tenodesis to support, especially with the increased pivot test or rotational stability. What we have from the studies that led with ACL revision as always, give you eliminate the high grade pivot shift, but it doesn't difference and it come to the outcome. This is another study, 2019. Again, a reduction of residual post-operative rotatory instability and degree pivot test. So in summary, anatomic revision ACL reconstruction is a complex procedure. Comprehensive clinical examination, radiologic assessment, and preoperative testing is a must. Difficulty include prayer tunnel widening and osteolysis, malalignment, concomitant injury, and the graft choice. Thank you.